technology and on and developing mobile applications to educate nursing staff, patients, and families. Dr. Michael has been active with Pediatric Nursing Certification Board since 2011. He has been a nurse, an assistant manager, and as a critical care a nurse for pediatric care. He started his career in health at a Navy hospital before becoming a nurse. So we are very grateful and very pleased to hear from somebody who has been a professional doctor for a long time and who can talk to us about his experiences and share them with us here in Brazil. Thank you very much, Dr. Michael Memi.
I want to thank you for the opportunity for presenting today to all of you. I wish I was there in person, hopefully in the future, but I am still very excited to give you my presentation. I'm going to go ahead and share my screen to show my slides. As previously mentioned, I'm a clinical assistant professor at the University of Florida here in Gainesville. I am a DNP prepared nurse practitioner with a specialty in pediatric acute care. I oversee the pediatric acute care and primary care nurse practitioner programs here at UF. And I've been working with DNP students on their projects since beginning my career in academia in 2019. Today, I want to describe to you how our students develop their DNP projects and how they're impacting practice changes at their practice locations. I want to start off by letting you know I have no disclosures. My objectives for today are to begin with a brief overview of the new AACN DNP Essentials. I also want to provide an overview of the DNP project requirements and quality improvement project process for our students. I will finish with sharing some of my recent DNP student projects and how they're impacting patient care. The AACN guidelines outline how the project should be conducted, and it should be the same for all students. This includes planning, implementation, and the evaluation components of the project. To identify the outcome of the program, our students must have the opportunity to integrate all of the DNP essentials into practice. However, not all of the essentials have to be demonstrated in the DNP project. The new essentials listed here on the next two slides have changed to offer domains, competencies, and subcompetencies. The domains are the same for undergraduate and graduate students. However, the competencies and subcompetencies are more advanced for the advanced practice nurse. For example, in the domain of nursing knowledge, the advanced practice nurse is required to translate scientific evidence into practice, as we compare that to the undergraduate nurse, who is required to identify concepts derived from theories from both nursing and other disciplines and distinguish that into their practice. We want to ensure that we capture as many of the essentials in the project as possible. In real time, many of the essentials will organically come together as the project unfolds. For example, in developing the project, the student may identify an issue which is derived from knowledge of nursing practice or a gap in nursing practice. This may include person-centered care impacting both quality and safety. Then in the preparation of the project, the student will need to develop interprofessional partnerships and implement the intervention. They may need to use healthcare technologies. So as the student works on the project, many of the essentials are addressed as they work through the entire project. This slide outlines the project requirements as detailed by the AACN Task Force on implementing the DNP project. We want the students to develop a project so that the impact patient care, healthcare outcomes, and implementation that is appropriate to their area of clinical expertise. We also want to view the problem through various lenses, such as at the micro, meso, and macro levels. They should be sustainable both financially and within political realities. Above all, we want this project to lead the way for them to continue to impact healthcare in future practice scholarship. Now I'd like to talk a little bit about how the student develops the project. They first begin by doing a literature review to find supporting information or to identify gaps in the literature. They begin by developing a PICO question, which includes population, interventions, influence or exposure, comparison, outcomes, and time frame. We have them develop a literature summary table, which will include all of the relevant articles that they found in their literature review. Next, they will complete an assessment of the practice location. This will include an evaluation of the current clinical practice and identify any issues or concerns with communication, knowledge, or workflow. Once the assessment is complete, they will develop their problem statement. This encompasses the phenomenon that needs to be addressed in order to develop a solution. Identifying the stakeholders is crucial to the development of the project. This will include everyone that will be involved or impacted by the project. They may have to develop interprofessional partnerships to address the issue at hand and to get their buy-in to developing a solution. If the stakeholders are not on board or do not believe in the project, it can make it very difficult or even impossible to complete. The stakeholders are seen at various levels within the organization. The project scope involves the work of or workflow that is needed to fulfill the goals of the project. A conceptual framework is developed, excuse me, and this is a group of concepts that are broadly defined and systematically organized to provide a focus, a rationale, and a tool for the integration and interpretation of information. I have identified the theories and conceptual frameworks for each of the projects that I will share with you from the students that I've worked with in the past. One thing that I learned early on when getting my doctorate in nursing practice was that the PhD prepared nurse works on the discovery of new knowledge within a specific domain, whereas the DNP prepared nurse translates that discovery and applies it into practice. So working on the DNP projects, we try not to focus our students on conducting research, but rather we want them to focus on quality improvement projects, whereas we can identify real clinical problems, evaluate the current evidence-based practice, and translate that into practice. The QI project can also allow for healthcare delivery innovation, program development and evaluation, healthcare policy, and even generating new evidence and knowledge. Now, I want to take you through the journey of how our students start with their project and then how they finish it. The students start their project right about the middle of their curriculum. The first semester, they are working closely with a very experienced DNP faculty to help them develop the project. The faculty work toward having the students identify the focus of their project, keeping it realistic and achievable. We often have students that want to solve all the world's problems in a single project, but we must keep them focused and develop them into achieving the project in order to graduate. They begin to develop the project scholarly paper in that first semester. Here they will complete the literature review, the PICO question, and the problem statement. In the second semester, they are paired with DNP faculty that will serve as their project chair. This faculty is carefully selected by having some background or experience in the topic of the student's project. For example, my field and specialty is in pediatric acute care and pediatric critical care. So students that have projects that fall within my specialty are often paired with me. This allows me to mentor the student and to keep them on track with achievable goals for the project. I can also because of my background and specialty, I can often aid in facilitation and identifying stakeholders, developing interprofessional partnerships, and helping the student navigate through healthcare systems. So the role of the DNP project chair is very important. In this second semester, they refine the project, get agency approvals, and if needed, we'll seek out an IRB approval for their project. In this semester, they will also make additional final revisions to that scholarly paper, as well as identify the stakeholders and define the project scope. In the third semester, this is where the project is actually initiated, or it's a continuation from the previous semester. They will provide an intervention, collect their data, and evaluate the results. Here is when they will complete most of the project. They will refine that scholarly paper even further, and then add the results discussion and identify any future implications of the project. The last semester, which is their final semester, they actually will tie in everything that's left remaining within the project. But the big part of this semester is allowing them to disseminate the project to the community. And this can be through healthcare organizations, directly to the stakeholders, national or local conferences, as well as nursing organizations. Here the paper is completed, and we as DNP faculty will encourage the students to publish their work, and we will help them develop a manuscript to be entered into journal publication. This slide is an example of what our curriculum plan looks like for our part-time pediatric acute care DNP students. I've boxed out and highlighted the areas in which they will work on their project. We actually offer them a course each of these 4 semesters so that they can focus and work on the project over the course of 4 semesters. Now, it is my honor to share with you projects from some of my students and colleagues who have completed their DNP projects within the last 2 years. This first project, supporting the role transition of advanced practice providers and implementation of mentoring program, was developed by my very first student, Dr. Emily Goff. She identified early in her observation at Children's Hospital in Orlando that there was a gap in the practice involving new nurse practitioners in their transition from their academic program into their very first nurse practitioner job. With the assistance of an agency sponsor at the hospital, she worked with them to identify the increase in growth of nurse practitioners in the acute care setting, but there was an extreme lack of mentoring for these new providers. In her literature review, she found that mentoring can be a powerful tool in the transition into practice. It can improve the provider's competence, job satisfaction, and deliver high quality healthcare. When she developed her project, she used the transitional advanced professional practice model in developing her intervention, this being her conceptual framework. She met with key stakeholders, which included an agency sponsor, nursing administration, and experienced advanced practice providers throughout the hospital. She worked with the administration on pairing the mentors with the mentees as they were hired during that onboarding process. In her original design, she wanted to follow the mentors and mentees for a 12-week period. And then she wanted to distribute an anonymous voluntary questionnaire to evaluate how the mentoring process went. This included role modeling, career support, and psychological support. Now, I'd like to give you full disclosure. Dr. Goff had met some extreme challenges at the very beginning of her project. In March of 2020, COVID-19 became a real problem in the United States. This impacted how she was going to conduct her project because many of the clinical environments had stopped allowing students to enter the practice, and the hospitals reduced the number of nurse practitioners they were hiring during that period because they were more focused on the adult population. She received much smaller numbers than she originally anticipated. However, she did have enough participation to report out on this and allow her to complete her pilot project. She originally was hopeful that she would have much different results. She found that the survey sample, there was not enough high engagement between the mentor and mentee. Now we feel that some of this was greatly impacted by the pandemic. However, she was able to complete her project on time in order for graduation. And this pandemic allowed her to really give good insight of how it affected her ability to complete the study. Aside from the pandemic, she did identify some significant key issues that she would like to change for future scholarship on this project. The first thing was that she identified a 12-week observation may have been too short. And in the future, she would like to evaluate this over a longer period of time. She suggested maybe doing it over 6 months to a year. She also wanted to fine-tune how we selected the mentors for the new nurse practitioner providers. She wanted to make sure that there was a better compatibility match between the mentor and the mentee. In talking to some of the new providers, she felt that there was some confusion on how they should communicate with their mentor. So she felt that establishing methods of communication between the two would improve the relationship and improve the communication between both. So as you can see, this project was completed despite the many issues that we came across. And she has indicated that currently her institution still utilizes this mentoring process, and she would like to do additional scholarship work to improve and refine this process for new nurse practitioners. This next project I want to talk about is a big issue that we have currently in the United States. And this is that many parents are either not seeking or are refusing vaccinations for their children because they have hesitation, either through questioning, political views, or other reasons. And in certain areas around the state of Florida, we are seeing an increase in pediatric practices that are refusing to take patients whose parents are refusing to get their children vaccinated. And that's because they want to protect all the children within their practice. So we're starting to see a large number of patients that are not getting vaccinated. So Dr. Turk developed her project to increase vaccination rates amongst those patients whose parents were hesitant to receive vaccination for their children. In her practice, her pediatrician and other nurse practitioners have made a decision to take on these patients that have been refused by other practices. What she would like to do is keep all their patients safe. Dr. Took a different approach when she wanted to educate her parents and her patients. What she wanted to do was to offer the parents education and an alternative schedule that could be personalized to meet the Center for Disease Control's guidelines over time versus on the Center for Disease Control schedule. Her project included both a nursing theory and a conceptual model. The theory of human caring by Dr. Jean Watson allows the provider to develop a relationship-based care to guide the delivery of care to improve patient outcomes. The health belief model is also a conceptual model that includes perceived susceptibility, severity, barriers, cues to action, and self-efficacy. Here, she was able to better understand the parents' intentions to guide vaccinations for their children. She developed an interview process with the families to discuss why they would or would not want to have their child vaccinated. She then provided education and offered a schedule that was developed by her and the parents. So, for example, if a parent was hesitant to have their child receive multiple vaccines at one doctor's visit, she would schedule them over several visits and not provide any additional cost to the parents, with the possibility of increasing their vaccines over a period of time. Her findings were very interesting. She demonstrated a positive effect using interviewing techniques and offering these alternative schedules. Using this method, the most significant increase in parents consenting to vaccines was found in the age group of 5 to 18 years of age. The group with the greatest impact were those with children whose parents declined all vaccines. She was able to get them to go from a no vaccine rate of 42% and reduced it down to just 2%. Now, her findings were very interesting for her and for her practice. She was very excited about implementing this new intervention for her patient population, but she did identify that there was a very small sample size. So with her scholarship, her intention now, after she has graduated, is to do additional studies and additional evaluations of her intervention to see if she can improve this over time with a much larger sample. She would also like to have this intervention applied to multiple different practice locations in various different demographic regions to see if the results are reproducible or if they are varied among different practices. This last presentation is by a DNP who just graduated and has now just become faculty here at the University of Florida. He is dual certified primary care and acute care nurse practitioner, and his project had some deep personal motivation. He has 2 children that have been diagnosed with autism spectrum disorder. So his project, he wanted to develop a healthcare toolkit that will assist children and families with autism in transitioning them into hospital care. Now, Dr. Roller works at a freestanding children's hospital in Orlando, and they had established a program years ago to assist patients with autism spectrum disorder. This program provided a clinical pathway to assist providers in caring for that population, especially for those that are being hospitalized. One thing that he realized by having both children with autism is that often this pathway was not implemented or had gaps in how it was implemented throughout the hospital. This pathway looks at the behavioral and developmental focus approach to prevent or minimize self-injury, maladaptive behaviors, aggression, anxiety, or withdrawal. Children with autism often have difficulty with transitioning from one activity to another. They often have rigid adherence to routines and rituals and are generally resistant to transition. So as you can imagine, hospitalizations can break their routine and initiate unwanted behaviors. Dr. Roller used the applied behavior analysis model that was developed by B.F. Skinner. This model emphasized the importance of identifying the anticipatory behavior and modifying the actual cause of the undesired behavior in children with autism. He discovered a gap in practice in that this clinical pathway was not often implemented. He identified a solution by developing a toolkit that could be integrated into the electronic health record that is a resource to all providers and screens all patients that are at least 2 years of age and older. He developed a screening tool that flags and requires providers to acknowledge the patient upon arrival. It is triggered every time the patient's chart is opened and any healthcare provider evaluates the medical record. It also triggered an order set that allows provider to place specific orders for this patient population. These are orders to provide supportive services such as child life, social work, behavioral health, music, and pet therapy. The order set also allows for the acknowledgement of medications that may need to be administered if all other de-escalation techniques have been exhausted. It also includes a nutrition consult to identify what specific food preferences these children may have. It also allows for physical therapy and occupational therapy to improve quality of life and assistance with activities of daily living. Within the toolkit, there's an admission checklist, as I just mentioned, there is the order set, and there's also a questionnaire. The questionnaire identifies how to communicate with the patient that may have limited communication abilities. For example, some of these children are nonverbal and may require assistive devices such as iPads or tablets with specific software to communicate with healthcare providers. It also identifies their level of anxiety and what risks they have for self-injuring behaviors. Another gap that he found was actual staff communication. And what he identified were issues in various locations within the hospital. For example, in the emergency room, within his toolkit, he identified that the rooms for these patients needed to be identified with a marker to let everyone know that there was a child being cared for with autism. He also made a multicolored symbol placed in the EMR, which quickly identified that this child has autism spectrum disorder or other special needs. He also implemented an annual required training module and supportive PowerPoints to help develop the staff and new providers. The outcome he found was tremendous. By including this toolkit within the electronic health record, he found that compliance went up almost 100%. This is an ongoing project that his hospital is now monitoring for utilization, and it's gone all the way up to the administrative level to ensure that it's implemented everywhere within their healthcare system. This slide here kind of goes over the questionnaire that he developed that's put into the electronic health record. Off to the right of the screen, this was the original clinical pathway that was developed for these children. By merging these two projects together, he's been able to improve compliance and to provide the much needed care for these children with special needs. He also made sure that within the education that the environment was inclusive of the child with autism. As you can see, there are various therapy lights, therapy modules and boards for them. So when they go into their rooms, they can actually have some things that may be familiar or calming and soothing for them while they're hospitalized. Here are some pictures of myself and Dr. Roller off to the left, and another student that I worked with who recently graduated here at the University of Florida. Are there any questions?
Thank you. Muito obrigado, Professor Michael, pela apresentação brilhante.
Thank you very much, Professor Michael, for a brilliant presentation. Right now, we have here in our chat people from all over Brazil, from our 5 big regions in Brazil. They are very excited about the way you could bring in a very objective way the difference in the projects, also in professional educational level. We are here in Brazil right now, being in this program for 18 years. But in Brazil, we still have a tradition in the academic programs. And then one of the issues that arise is what are the vital points to make a difference between academic background and professional background in your view. Could you tell us about that?
Can you repeat the question one more time?
Na sua
Uma vez?
claro. Na sua visão,
In your view, what are the criteria to distinguish the academic programs, the PhD and the DNP? How could it make a difference between them?
Yes, I think one of the biggest things that we see in a difference between both programs is we work as partners, right? So the PhD prepared nurse or nurse practitioner, they actually are in, they're looking for new discovery, they're looking for new evidence, and they're looking for information that can be utilized within the clinical setting. The DNP is an actual clinical provider. These are nurse practitioners that are working directly with patients at the bedside on a regular basis. So they take this new evidence from the PhD and they apply it into practice, or they test it into practice to see if they're making a difference at the bedside. They can also give good feedback to the PhD on what is and what is not working, and which may allow for new discovery or for refining how their projects are being developed.
Sim. Temos dois programas de doutorado.
We have two doctorate program in Brazil. Professional doctors, I could say. One in São Paulo, the state of São Paulo. The Professor Rodrigo Jason is commenting on that. It's very interesting to see the convergences between the professional doctorate in Brazil and in the United States. We really need more and more to provide this proximity, so we must get closer in our relations.
Yes, I agree. I think having those relationships and having the doctoral prepared nurse practitioner or nurse at the bedside really improves how we change care and how we impact care on a regular basis. Many of our DNP scholars have a scholarship project, just like the projects I just presented, that they want to continue in their practice, to continue to refine and to continue to improve their practices.
Sim. E essa era uma pergunta minha para...
It could be my following question, my next question. Amongst the challenges when we are building a project of change implementation, for me, the time to check the changes is a challenge. So in your assessment, in your experience for carrying out projects, what are the strategies you make use to check the changes for the vaccination, for instance? I can have a short-term effect and long-term effect. What are your suggestions for this project checking? Because in Brazil, we have 4 years to have a professional doctorate. What's your experience in the US?
Yeah, so the DNP programs are right around 3 years to 4 years. They start their project here right around the middle of their program. So they usually have about 1 year to 2 years to complete the project. So some of the strategies that we use, number one, we want to make sure that their project is focused enough and it's refined to be achieved within that period of time. So many of our projects can be piloted projects or projects that are over a short period of time. But one strategy that we've used to ensure how we can follow up on these projects is we may start with one student who initiates the project, and then another student may come in right after them and continue that project over a longer period of time. So it's not just one student doing the completion of the entire project. We may stage it down into different segments so that we can monitor it over longer periods of time, just like the vaccine rates. And we've done that in various different settings. I have another group of students that wanted to evaluate what the parents' current knowledge was about getting vaccinated. So they started off with that project, and then the next students will come in to implement strategies to see if they can actually improve their vaccination rates. So we do try to strategically plan these projects, number one, to be achievable for their graduation time, but we also want to make sure that we get good results over time.
Excelente, excelente.
Excellent. There are several projects between professors and students involved in the project. So it brings not only investments, financing, it's an issue. When you have a large project, you can have a grant for that. How has it been, the assessment of investments and funding for professional programs in Brazil? Is it easy for you to obtain this funding project with a bigger number of people so that you can include more students, scholars?
Yes, we have projects where we can get funding, although in my experience, we haven't actually sought out large grants. We actually go after smaller grants that will help fund the project as needed. And I'll give you an example. When I did my DNP project here at the University of Florida, I developed a software application to monitor pediatric cardiac patients after they go home after surgery. And it allows us to monitor them to see if there are any subtle changes in their presentation to identify risks of mortality and morbidity. And I was able to obtain a small grant to hire a software engineer to develop that software and to implement it into practice. So there are opportunities for us. I don't know if I could say that it's easy, but there are grant opportunities out there for small quality improvement projects, just like the one I mentioned and other projects that we have. And the grant funding is usually smaller. I would say probably in the couple of $1,000 range, not necessarily in much larger grants, and I would say in the $1 million range. Now, we have had projects where the faculty might put in for a large grant, and then students will come in and work on those projects with the faculty. So they'll develop their DNP project under the umbrella of a grant. So that will allow them to have funding for those projects as well.
Nessa questão do financiamento.
In this issue for the funding, I'd like to ask you if the student get this grant, this financing. It's a question that Lorena, one of the organizers, has asked. Among the partnerships and the settings between the services and the university, is there a counterpart? Is there a sort of financial services, and how this partnership is established?
Yeah, as far as grant funding for students, I think we set that up with the faculty member that's their project chair, and they oversee how that money is being spent and how it's being distributed. So I believe the grant that I received when I was in school went to the College of Nursing, and then when I needed to make payments for the software or for any type of finances, I was able to just request that from my faculty, and then the money was distributed. Did I answer the question?
Então, por exemplo, se você atende.
So, for example, if you, in an advanced practice nursing training, they will render a certain service. That's free, and that's a return that they received. Does that happen as well? Is that what it is in terms of the project?
Yes, if the student is doing a project for an agency, there is no charge for that. We actually provide that service to that agency. So, for example, the Autism Healthcare Toolkit, that was developed by the student. He worked with that hospital's electronic record, and that was provided to them at no additional cost. So many of our academic partners at different hospitals really enjoy having DNP students because they do bring these projects in, and it isn't at any additional cost for them. There's no cost for manpower because they're students, and there's no additional cost for implementation as we implement it. Now, it's their choice if they want to choose to implement it, or if they want to utilize it as it was designed, or if they want to build upon it. And that's often the case that we find with our students.
Entendi. Muito interessante, né? Essa atividade da implementação.
Very interesting, this activity of the implementation. It's hands-on practice. In Brazil, there's an interesting issue that our professional master's courses, they have the 500 practice hours. And these practice hours is what they make of their projects. So in actual fact, they are practice nurses. That's very important. When it comes to admission, we have learned that when you admit a student from a professional master's, they need to have this practice background to do this specializing training, quote, training in their work. So we have that in Brazil as well.
Yep.
And here is a final question here
Okay.
by Paula, by Professor Paula and Jusimara. Their question is for all listeners here with us. What would lead a nurse to choose between an academic uh, doctorate and the professional doctorate? I'm sorry, yeah, it froze at the wrong time.
No, that's okay.
There are many issues here. If they want a professional or an academic. So there is that issue. Was that clear, Professor? Because it
Yes,
froze just at the wrong time.
Oh, that's perfect. That's perfect. So a lot of our students that choose the doctorate in nursing practice, the clinical doctorate, are those students that want to impact change at the bedside and still practice. So I think that's their driving force. A lot of our academic doctorates are researchers. So they spend a lot of time doing research either in a laboratory or in an office or however they choose to do that. Our DNP students really want to continue working as a nurse or a nurse practitioner and apply the changes as the evidence is available. And oftentimes we want to work with the researchers. There's a good relationship between both doctorates because we bring a lot of questions to the researchers and then we develop plans to either conduct research or implement change. So I find that a lot of our students really like that. And then if the student is not as interested in research, but they want to get their doctorate degree to make those clinical changes at the bedside, the DNP is a more focused degree for them. So we see, students with both interests, and they do make that decision, and we help guide them as well. As the student is admitted, if we find that a student is more focused on research and they're in my DNP program, I will then guide them over to our research team and allow them to focus on that PhD, and vice versa. We find that goes both ways. We have very few that get both. One of my colleagues has both a PhD in research as well as her DNP. And I believe she started off with her DNP first and then went back to get her PhD because she wanted to focus more on research later in her career. So I don't know that necessarily someone has to do that, but often our students want to make a choice, and usually their choice is apparent up front, whether they want to work clinically or do they want to work more in research.
Muito bom. Eu acho que isso precisa
Great. I think that's something we need to adopt here. You need to take a new exam, but we do need that guidance. This has happened to us. A student who was in professional masters, and her mentor said, I think you have more a faculty profile. So she went to the academic PhD. Today, she's a professor. So the mentorship given by the professor, there was a student by Professor Omara, and the guidance was very spot on. It's a great thing to be able to guide your student. We have reached the end. Thank God everything worked. Rosemary congratulates the interpreters. That's not our words. And logistically, everything went well. I'm glad we had great translation. I'd like to thank Anna Sess from research and thank her for having presented this platform. I'd like to thank Professor Michael, Professor Jeanne Marie, who gave us this excellent hint to bring a great professor with hands-on experience, and many students want to foment exchange, and maybe, who knows, we'll be able to hold international projects / partnerships, professional doctorates, and open up these spaces in global professional doctorates. Thank you very much, Professor Mamie. And it was great. Thank you so much.
Thank you very much. Take care.
Muito obrigada, viu, a todos.